A very good evening. Extending a very warm welcome to all the delegates, and thank you very much for joining us. We are now at the last session of our laryngology webinar series. This session is going to continue on the previous topics that have been covered in swallowing, and we are going to have a few more talks on swallowing itself. Today's speakers would be Dr. Rohan Bide, Dr. Shan Vijayshekharan from Australia, and Dr. Juliana Ongsuwan from US, and myself, Dr. Nilanjan Bhaumik from India. So without further ado, I call upon Dr. Rohan Bide to present his first lecture on the anatomy, the functional anatomy and physiology of swallowing.
Thank you so much for the warm welcome, Dr. Bhaumik.
Dr. Heba, I think, will just be taking over, and then Dr. Rohan Bide would be starting his talk.
Hello, everybody. I'm Dr. Heba from, I'm laryngology fellow in DMH Hospital. So our first talk will be presented by Dr. Rohan Bide about functional anatomy and physiology with following clinical correlations. And Dr. Rohan, he is an ENT head and neck surgeon working in Charing Cross Hospital in London, completed his laryngology fellow of Royal College of Surgeons, and he's an editor-in-chief Journal of Laryngology and Voice. So Dr. Rohan, welcome, and may you start your presentation.
Thank you so much, Dr. Heba, Dr. Bhaumik, for the warm welcome, and the entire team of LVF for the invite. I'm going to start sharing my screen now, so just give me a thumbs up if you can see it. And happy with that, Heba? Perfect. So my today's talk is going to be on anatomy and physiology of swallowing. My name is Mr. Rohan Bide. I'm one of the consultant ENT surgeons. I actually moved job from Charing Cross now. I work at the University Hospitals of Northamptonshire. These are my two hospital attachments, Kettering General Hospital and Northampton General Hospital. And it's a university hospital attached to the Leicester University. Disclosures, I don't have any images which are of my own in this talk. So I've picked up the images of the internet, and it's a non-sponsored talk. What's swallowing? It's traditionally described as a reflex, but the process is more probably regarded as a programmed motor behavior. It's a mixture of voluntary and reflex actions when food or liquid stimulates the sensory nerves in the oropharynx. Now, in a 24-hour period, an average person can have around 600 to 1,000 times they can swallow. While consuming food, an average person usually swallows around 150 times. The problems associated with swallowing can impact life dramatically, and especially the quality of life. And the inability to swallow can affect the nutritional status and also exacerbate other underlying causes or diseases which are there. Coming to the anatomy, there are 55 muscles, 22 pairs. The one muscle which is not paired is the cricopharyngeus in the oropharynx, larynx, and the esophagus, which are responsible for swallowing. Now, there are 5 cranial nerves which supply these nerves. There are 2 cervical nerve roots, and there are some centers within the central nervous system. And the 3 main regions involved are the oral cavity, as you can see over here, the pharynx, and the esophagus. The laryngeal adytus is the one which, as I can point out over here, is the one which opens into the from the pharynx into the larynx, and the epiglottis is the one which originates from the hyoid bone over here and is angled upwards and backwards, covering the adytus to the larynx. One more very important structure is the hyoid bone. It forms a mechanical connection to the cranial base, the mandible, sternum, and thyroid cartilage via these muscles which it attaches. The vallecula, you can't see it over here, but it's a space between the pharyngeal surface of the tongue and the epiglottis, and the piriform sinus is the space between the pharynx lateral to the larynx. The constrictor muscles are the ones which flatten and contract the pharynx while they're swallowing. And the cricopharyngeus, which is at the upper end of the esophagus, it closes the upper end by compressing it at the back of the cricoid cartilage somewhere over here. Coming to the innervation, there are, as I said, there are 5 nerves. The trigeminal is the one which supplies the muscles of mastication, mylohyoid, tensor veli palatini, and the anterior belly of the digastric. Bring them to the higher centers in the brain are the trigeminal, glossopharyngeal, and the vagus. Trigeminal takes inputs from the teeth and the gums, palate, as well as the roof of the pharynx. Glossopharyngeal is from the posterior third of the tongue, pharynx, and some area of the tonsil. Whereas the vagus is the workhorse over here, which takes major sensory inputs from the pharynx and the larynx. Now, these brainstem centers are central. There are 2 main central pattern generators over here. There's a dorsomedial and a ventrolateral tract. Now, they mainly involve the nucleus of tractus solitarius and the nucleus ambiguus. They program the directing of the sequential movements of the various muscles involved. They're activated by descending pathways from the motor cortex, from the higher centers, the corticobulbar tracts, and the ascending pathways from the sensory structures within the oropharynx and the esophagus, the ones which I just described in the previous slide. Coming to a bit more theory, I have a diagram over here which explains where these centers lie: the dorsomedial pattern generator and the ventrolateral pattern generator. The dorsomedial one is the one which is close to the nucleus of tractus solitarius, over here somewhere. And it is responsible for initiation, organization of the swallowing sequence. The ventrolateral pattern generator is the one which lies near the nucleus of ambiguous. And this is the nucleus ambiguous over here, lies somewhere over here. And it primarily serves as a connecting path to a motor nucleus, which controls the motor output of the pharyngeal musculature and the proximal esophagus. Now, a point to note is both these nuclei are very close to the glossopharyngeal nerve nucleus as well as the vagal nerve nucleus. Going above the midbrain now to the brains, going above the midbrain now to the cortex, there is inferior precentral gyrus, which has a cortical representation of the tongue and the face. The supplementary motor area, which is involved in volitional swallowing, and anterior cingulate cortex, which helps in monitoring autonomic and vegetative functions. There are also other areas involved in swallowing, again in the brain. Anterior insula, particularly on the right, which allows gustatory and intraoral sensations to modulate swallowing. And lesions increase the swallowing threshold and delay the pharyngeal phase of swallowing. Cerebellum, especially on the left-hand side, it helps in coordination, timing, and sequencing of the swallowing. The putamen is also activated during volitional swallowing. Now, the first part of the talk is over, and then the second part begins with physiology. The physiology of swallowing is divided into 4 phases: oral preparatory phase, oral transit phase, the pharyngeal phase, and the esophageal phase. The oral preparatory phase and the oral transit phase ends by delivery of the bolus into the oropharynx. The pharyngeal phase carries it to the upper esophagus, and then the esophageal phase all the way to the stomach. The first 2 phases are voluntary under cortical control, whereas the second 2 are involuntary, controlled by the brainstem. Oral preparatory phase involves chewing. The food is reduced by the grinding action of the teeth. The lips maintain a tight seal. The buccinator does the same thing for the cheeks, and this prevents food entering into the vestibule. The buccinator also keeps the cheeks taut and prevents injury to the cheeks, especially while chewing. Now, this phase is very, very important. It's quite often overlooked, but there are quite a few muscles and activities involved in this phase, preparatory phase. The bolus formation appears to involve several cycles of food being transported from the anterior to the posterior part of the tongue through the palatoglossal and palatopharyngeal arches into the bolus. And this accumulates on the oropharyngeal surface of the tongue, also called as retrolingual loading. Now, throughout this phase, the lateral and the rotatory tongue movements are crucial for normal bolus formation. End of this phase is marked by the tongue holding the bolus of the food that has been formed against the hard palate in readiness for transport to the posterior part of the oral cavity. The pressure that the food bolus places on the posterior oropharynx activates the oropharyngeal sensory receptors of the glossopharyngeal nerve, which then sends signals to the solitary nucleus, the one which we saw in the anatomy. And then the swallowing center outputs signals to initiate the pharyngeal phase and followed by the esophageal phase. The oral propulsive stage also has a few functions happening together. The apose soft palate and tongue form a tight seal that help to prevent the premature entry of the bolus into the pharynx. A shallow midline gutter in tongue to accommodate the bolus. I've marked the muscles involved in bold over there for anyone who's reading. Emptying of the longitudinal gutter posteriorly, elevation of the anterior and the mid-tongue hyoid bone in the floor of the mouth, and then the relaxation and forward movement of the posterior tongue. Overall, the effect is to sweep and squeeze the bolus towards the pharynx. After the propulsive stage comes the pharyngeal phase. Sorry, someone's microphone seems to be on. Okay. Rapid sequential state activity which occurs within a second is the pharyngeal phase. And the pharynx changes from being an air channel to a food channel. There are two crucial biological features which happen in this phase. There is airway protection and the food passage, obviously. Now, airway protection has to happen at the top as well as the bottom. The top bit is closing of the nasopharynx, which is done by the superior pharyngeal constrictors, the palatopharyngeal, forming a variable ridge called as the Passavant's ridge. Now, it occurs at the same time as the bolus head comes into the pharynx, and it prevents the bolus regurgitating into the nasal cavity. The bottom bit, also called as the laryngeal adytus, needs to be closed to. There are three layers in which it closes. The vocal fold seals the glottis. The hyoid bone and the larynx pull upwards and forwards, which tucks the larynx under the base of the tongue. And the epiglottis, which also forms a seal, it tilts backwards to close the laryngeal vestibule. The second part of the pharyngeal phase is the food passage. Now, elevation of the hyoid expands the hypopharyngeal space and relaxes the upper esophageal sphincter, which is also raised by several centimeters. The bolus passes over the reflected anterior surface of the epiglottis and is swept through the laryngopharynx to the upper esophageal sphincter. The tongue driving force or the tongue thrust pressure force is a positive pressure that squeezes the bolus towards the laryngopharynx. Sorry,
Excuse me, those their mic is unmuted.
Okay, thanks so much. The tongue driving force or the tongue thrust pressure force is a positive pressure that squeezes the bolus towards the laryngopharynx. Yeah? And the pharyngeal constrictors generate a positive pressure wave behind the bolus. This sequential contraction may facilitate the clearance of the pharyngeal walls. Coming to the last phase, esophageal phase, it involves the relaxation of the upper esophageal sphincter, propulsion of food bolus into the stomach. Now, the upper esophageal sphincter actually consists of three muscles: the inferior pharyngeal constrictor, the cricopharyngeus, and the proximal part of the esophagus. There are three factors which are responsible for the relaxation. The actual relaxation of the cricopharyngeus muscle, which precedes the arrival of the bolus, the contraction of the suprahyoid and the thyroid muscles, which pull the hyolaryngeal complex forwards, and this also opens up the sphincter, and it's an active opening process. And the passive pressure of the descending bolus, which opens up the upper esophageal sphincter. Once the food is in the esophagus, the bolus is propelled by peristaltic contractions down to the lower esophageal sphincter, which opens momentarily to allow the bolus to enter the stomach. And the esophageal phase of swallowing is much more variable It can last for anywhere between 8 to 20 seconds, involving multiple waves of peristalsis in the esophagus. My last concept, which I'll discuss, is something called a synchronization of swallowing with respiration. I believe this is very important physiology of swallowing, and I'll just highlight the steps involved in this. When you're swallowing, breathing ceases briefly. The physical closure by elevation of the soft palate and tilting of the epiglottis also contributes. There is neural suppression of respiration in the brain stem. And then the respiratory pause continues for around half a second to 1.5 seconds. And this is followed by expiration immediately, which reduces the risk of aspiration. This concludes my talk. Thank you so much for your time and patient listening. I believe we'll be taking questions in the end. And I'm sure the rest of the speakers have more pictures and videos with more clinical talks following mine.
Yes, thank you, Dr. Rohan, for your valuable presentation, and we will take the questions later after the presentation. So our next topic will be given by Dr. Nilanjan Bhowmick, and it will be about fiber optic endoscopic evaluation of swallowing. Dr. Nilanjan, he's a consultant ENT at Dinanath Mangishkar Hospital in Pune, and he has been an invited speaker to several national and international conferences and seminars. He has been practicing laryngology since last 10 years, and also a faculty for esteemed RTS fellowship in laryngology at Dinanath Mangishkar Hospital. So welcome, Dr. Bhowmick, and you may start your talk.
A very good evening. This is the concluding module of the laryngology webinar series, and today I'll be speaking on fiber optic endoscopic evaluation of swallowing. So it's very important to have a thorough knowledge of the phases and the various movements therein during all the phases of swallowing to understand and evaluate dysphagia better. Swallowing starts off with the oral phase, which again is then subdivided into the oral preparatory and the oral transport phase. What happens in the oral preparatory phase is the food starts forming, or rather the anterior tongue muscles and the oral muscles start forming a bolus. At the same time, the posterior tongue seals off against the soft palate so as to cause, or rather prevent, leakage of food from the anterior tongue into the pharynx. Then begins the oral transport phase, wherein the anterior tongue again lifts up and propels the food back towards the posterior part of the tongue, which triggers off the pharyngeal phase, which is probably the most complex of all these stages. Herein, the food gets propelled from the base of the tongue past the esophageal sphincter, with a various lot of movements occurring in meanwhile, past the esophageal sphincter into the esophagus. And then begins the esophageal stage, which propels the food from the upper esophageal sphincter through the lower esophageal sphincter into the stomach. Now, Leopold in 1997 classified dysphagia based on the 5-stage process of ingestion. That's pre-oral, which was the anticipatory stage, the preparatory dysphagia, lingual dysphagia, pharyngeal and esophageal dysphagia. Now, our discussion today will center primarily around pharyngeal dysphagia. These are a few studies out here which have tried to determine the accuracy of localization of symptoms by the patient. What has been the net result of all of these studies is that patients can reasonably accurately determine
or rather localize oropharyngeal dysphagia to the oropharynx, but not so much so for esophageal dysphagia. So what are the symptoms of oropharyngeal dysphagia? You see, the most important and the most common symptom is the patient complains of inability to initiate a swallow altogether. They sometimes get oral stasis or oral residues, oral stasis of foods. They sometimes cough on feeds, occasionally have nasal regurgitation. All of these symptoms will begin immediately after the initiation of a swallow. So when these are the symptom complex that the patient presents with, either one of these symptoms or multiple of these symptoms, our thought should go towards oropharyngeal dysphagia, and the primary modality of investigation for oropharyngeal dysphagia is fiber optic endoscopic evaluation of swallowing, or FEES. Now, FEES, the first paper was published in the 80s by Dr. Suzanne Langmore and her colleagues, and then since then on, FEES has been regularly being done both by SLPs as well as ENT surgeons alike all over the world. So what exactly is FEES? It is the static and dynamic evaluation of the structures involved in swallowing, along with laryngeal sensory testing. Also, during the process of FEES, we evaluate any rehabilitative measures that we take for the patient. FEES is a combination of all of these. Now, video fluoroscopy had long been considered the gold standard evaluation for oropharyngeal dysphagia. Now, the jury is still out as to whether FEES is presently the gold standard or VFS is. But then what can be understood from the various papers that have come into being since FEES has come into being is that FEES definitely gives a better visualization of the food boluses in the oropharynx. They also give us a better visualization of the channels of flow of the food. It's obvious that since you're looking through an endoscope, you get a better understanding and a better visualization of the laryngeal movements that occur during a swallow. The surface anatomy, mucosa, these can be evaluated better. What also can be seen well is the velopharyngeal closure or the velopharyngeal competence. There are recent studies which have also stated that the aspiration and penetration both can be better evaluated on a FEES as compared to a video fluoroscopic study. So FEES is done with a nasolaryngoscope roughly around 30 centimeters in length. It usually has a chip-on-tip camera which gives us better visualization. The patient is usually in the sitting position in front of you. Sometimes intensive care patients may arrive to your ICU beds, which you can do in the semi-reclining position. After initially doing a nasolaryngoscopy and assessing the status of secretions in the pharynx, and also asking the patient to conduct a few dry swallows so as to see for the various movements, we go on to give the patient feeds which are colored. These feeds vary in consistency from thin liquids to hard solids with 2 or 3 consistencies in between. When we keep the endoscope in the nasopharynx and just behind the uvula, what can be visualized is somewhat like this. You see a bolus of food appearing over the base of tongue, and then a whiteout of sorts obscures our vision, and then it's gone. The food disappears. If you're fortunate, you might be able to appreciate the food channeling around both the sides of the epiglottis, again the whiteout, and then the food should disappear. This is what a normal swallow would appear in an endoscopic examination. However, seemingly simple, there are a lot of complex movements which occur during this 1 to 2 seconds, which facilitate this smooth movement of the bolus from the oropharynx into the upper esophageal sphincter and into the esophagus. We'll just play short videos of each of these movements to demonstrate how a normal movement looks like. Each of these videos is conducted with a dry swallow, so as to give better visualization. What sets off the initial pharyngeal phase is the base of tongue elevation, wherein the tongue base elevates, pushes against the epiglottis. Almost at the same time, the soft palate rises up, closes off the nasopharynx. Now, this serves two functions. One, of course, is prevent food leakage from the oropharynx into the nasopharynx. The second function is to create a seal effective enough to facilitate something called a pharyngeal squeeze. Now, pharyngeal squeeze or a pharyngeal contraction is when the lateral pharyngeal walls come together and squeeze the food bolus straight into the upper esophageal sphincter and into the esophagus. This is how it appears. This is a big reason why the whiteout or absence of visualization occurs. The pharyngeal contraction should appear exactly like this. You see the lateral pharyngeal walls, and you'll see them slowly coming together. And that's that. Alongside these movements, there are two other movements which are occurring. One is the epiglottis retroflexion, wherein the epiglottis retroflexes closes of the laryngeal inlet, and at the same time, the larynx elevates too. You can appreciate out here the epiglottis returning from the retroflexed position. The laryngeal elevation serves two functions. One, of course, is as the larynx elevates up, the epiglottis closes over it, closing off the airway. The second function, of course, is opening up of the cricopharynx, wherein the food gets channelized and enters into the upper esophageal sphincter and esophagus. So the laryngeal elevation is an extremely important function. What can be done and should be done is laryngeal sensory testing, wherein the endoscope is slowly advanced and one of the aryepiglottic folds is slightly touched, which elicits a response like this. The laryngeal adductor reflex where the larynx closes off. This is how we do a sensory testing for the larynx. Now, what can go wrong during a swallow? So any of these multiple things can occur. Impaired bolus clearance when bolus persists on in the pharynx even after completion of a swallow. Misdirected bolus wherein the bolus moves in a direction which it should not be. Poor oral containment of food wherein the food slips into the pharynx even before the patient has started a swallow. And a mistimed swallow wherein the various structures involved in swallowing may not be, or rather may be dissynchronous to each other, or alternatively, the swallow itself takes an inordinately long duration. So let's talk about spillage, which is premature movement of the feeds into the pharynx. Now we have already discussed the fact that the posterior tongue during the oral preparatory phase rises up and seals off the pharynx so that the food does not slip inside. But then when this is not happening effectively enough, part or the whole bolus can spill over into the pharynx even before the patient has initiated a swallow. This is what is called spillage. Now, this could be because of poor oral containment of feeds, because there is absent tongue movements, the base of tongue is not elevating sufficiently, there's a poor glossopalatal seal. Occasionally, it can even occur because there's a delayed pharyngeal trigger, wherein the pharyngeal phase of swallowing does not start off and the food reaches the pharynx. It's usually said to be because of the involvement of either the 10th, 11th, or 12th cranial nerves, or a combination of them. Now, the other abnormality that we can occasionally see and very commonly see during a fees examination is residues. Now, residues can occur at one of two places. Vallicular residues, it has been conclusively seen that vallicular residues occur because of either a reduced tongue driving force, which is the more common pathology, or sometimes because of a poor pharyngeal contraction. Now, reduced tongue driving force can be seen in patients of Parkinson's, motor neuron diseases. The other location for residues are the piriform fossa and the postcoit region. Now, again, there are two different reasons for this. One is, of course, a weak pharyngeal contraction, as I was just discussing, which can be seen in patients of amyotrophic lateral sclerosis. or alternatively something called cricopharyngeal dysphagia. A cricopharyngeal dysphagia again can happen because of one of three events. One, of course, is cricopharyngeal spasm. Two is poor laryngeal elevation. And three is poor pharyngeal contraction. Cricopharyngeal dysphagia is commonly seen in brainstem strokes. So these are the causes of pyriform fossa and post-cricoid residues. Here you'll see a video wherein you'll note that the tongue base is not elevating sufficiently enough, and also the lateral pharyngeal walls don't come together very nicely to cause a good pharyngeal contraction. As a result of it, you'll notice that the food is piling up in the vallicula, causing vallicular residues. This here is a video of pyriform fossa post-cricoid residues where you'll notice that the larynx is not elevating sufficiently. As a result of this, the cricopharynx does not open up, and because of which there is food piling up in the pyriform fossa and post-cricoid region. Now, this is dangerous from the viewpoint that as the food keeps on accumulating in the pyriform fossa post-cricoid, a part of the feeds can start spilling over into the laryngeal vestibule, causing penetration. Now, penetration is movement of the feeds into the laryngeal vestibule without crossing the vocal cords. Now, what's important out here is to know that penetration is caused either because of a poor cricopharyngeal opening, because of increase in residues in the cricopharynx post-cricoid region, or because of spillage, as we have discussed earlier. What's again important is to note whether on subsequent swallows, whether the patient can clear these penetrated boluses, or they go on to become aspirates, which look like this, wherein the food boluses move beyond the vocal cords. Now, the usual associated movements or lack thereof in an aspirating patient is spillage, incomplete laryngeal closure, poor laryngeal sensations, and a poor cough and residue buildup in the pyriform fossa post-cricoid. The usual causes of aspiration are neurological impairment in conditions such as strokes, focal neurological impairment like a vocal cord palsy, a poor cough reflex, supraglottic diseases, and sometimes mechanical factors such as a tracheostomy tube or a Ryle's tube can also cause aspiration, as we can see in this video out here, wherein you'll note that there's a Ryle's tube in the left pyriform fossa, there's residue buildup around the Ryle's tube, and part of the residue is going on into the larynx and causing aspiration the way it is. What is also important to note is whether the aspiration is associated with a cough or it's without a cough, which is called silent aspiration, which effectively means that the patient cannot sense the aspirate, or the patient's cough is weak so as to not enable him to expel the aspirated material, and this can be quite dangerous. As I was mentioning earlier, FEES is also a modality to understand or give feedback about your therapeutic measures. So compensatory or rehabilitative measures that we undertake during a FEES examination is also something that we can get feedback on during the examination itself. Here is just an example of what I was just talking about. So this is a lady with vallicular residues. You can see poor pharyngeal contractions, poor tongue base elevation, and residue buildup. So what we did during the examination itself is ask the patient to flex the neck forward, or rather do a chin tuck maneuver, and ask her to effortfully swallow the bolus. What could be seen on the FEES examination immediately is that in spite of the residue buildup, as she does a chin tuck maneuver and an effortful swallow, the residues start getting cleared. And you see That's how it is. So this is the sort of feedback that you can receive during the FEES examination itself, telling us or letting us know what could be the therapeutic maneuvers that can be initiated in a patient. This is the general format of a FEES reporting that's used. Mention needs to be made about ice chip boluses. You see, there are patients who we suspect will most obviously aspirate, or patients in whom we are not sure whether they'll swallow or not. In these patients, a block of colored ice is kept over the patient's tongue. Now, the cold induces the patient to start swallowing, and since it's water, as it goes down, even if he does aspirate it, it's relatively safe. So ice chip boluses in patients who we have suspicion of possible aspiration, and if the ice chip boluses he does aspirate it, we do not go on to give him feeds. Now, I urge all of those interested in dysphagia to go on and read this paper out here. They have classified the dysphagia phenotypes on endoscopic examination in patients of neurogenic dysphagia, where they have found that there's the various neurological problems, and the most common dysphagia findings, or rather the FEES findings that you can see on an examination. So what's been commonly noticed is that residues in the vallecula and residues in the piriform sinus are probably the most common findings that are noted. That is somewhat akin to what our studies have shown us, wherein of all the patients of oropharyngeal dysphagia undergoing FEES over the last 1 year, we've seen that strokes obviously are the most common cause, and that too MCA territory strokes followed by brainstem strokes. Commonest findings we found were residues in the vallecula, and nearly 50 patients, or 20% of our patients, had aspiration, and among them around 12 patients had silent aspiration. Now, what's the clinical impact of FEES? Studies have shown, and our experience has shown us too, that it leads to earlier decannulations and earlier Ryle's tube removal. What is also seen is that nearly 50% of the patients, you will be able to change the feeding strategy, and in a substantial proportion of them, there is upgradation to oral feeds. It has definitely improved the mortality as well as the morbidity rates in neurological patients. So that's how FEES works. And while a lot has been said about FEES, a little mention needs to be made about this oral fiber optic endoscopic evaluation of swallowing. So while FEES is an excellent tool for oropharyngeal dysphagia, oral dysphagia or oral phase of swallowing cannot be very well evaluated on endoscopy. So what has been devised is an extension of the FEES procedure, wherein the endoscope is taken through the nose, and once it has reached the oropharynx, the scope is retroverted in a way to get a retroverted image of the oral cavity, and then the patient is given feeds. During these feeds, you can visualize the tongue movements, the masticatory movements, the bolus formation. Okay, what is more important is you can evaluate residues. Sometimes if the tongue is not coming in contact with the soft palate, you can visualize that, and also evaluate spillage. Some of these findings have been compared in a paper with VFSs and have been found to be valid. So this is definitely something which is worth going forward with. The only problem with this procedure is, since we move on from the nasopharynx into the oropharynx and almost go over the base of tongue, the patients tolerate this procedure a little less. So this is just an OFEES that we have done just to show what the procedure is like, wherein we go past and alongside the uvula, we invert the scope so as to get a retroverted view of the oral cavity. So that's feeds coming into the oral cavity, and then this is post feeds where you can see the oral cavity. There's no residues or oral stasis of feeds. And of course, even this involves a whiteout wherein the tongue comes in contact with the soft palate and you'll not be able to see anything at that point. But then that effectively shows us that there is good contact and there is proper movement of the feeds from the oral cavity into the pharynx. And finally, functional esophagoscopy, which again is a sort of extension of the FEES procedure. However, in this, longer scope is involved, and what can be done is, once this is primarily for esophageal dysphagia, wherein we suspect patients having some motility disorders in the esophagus, wherein we could just pursue a bolus of food and through the esophagus as it goes down from the upper esophageal sphincter through the esophagus and through the lower esophageal sphincter. This gives us a fair idea about the esophageal transit of food, whether there is stasis of food or there's a holdup anywhere, and whether there's any motility disorders involving the esophagus. This is again something worth exploring. So FEES is a very well tolerated and safe procedure, and the most common complication, of course, is discomfort, occasionally epistaxis. Laryngosspasm, of course, is a feared complication, but then something which occurs very rarely. Same for vasovagal episodes, is probably something which can occur, but then I have yet to encounter one. So it's a fairly safe procedure and can be done with ease in the OPD setting. It's important to know when to do a FEES examination. Oropharyngeal dysphagia, based on the patient's symptomatology and the patient's localization, has to be diagnosed before we go on to do a FEES examination. Now, during a FEES examination, the pharyngeal movements, the laryngeal movements, and the bolus behavior, and what is lacking will help us determine what sort of therapy we can give. And if we do plan a therapy during the examination, it would be very easy and very convenient for the patient if we get a feedback of the sort of improvement that the patient is getting with these compensatory rehabilitative measures. It's always nice to have a speech language pathologist during the examination along with you, so as to ensure that any maneuvers or any techniques that you would like to implement during the procedure can be done in the same setting. So thank you for hearing me out.
Thank you, Dr. Womack, for sharing your experience. The next talk will be by Dr. Shayan. Professor Shayan Vijay grew up in Perth, studied at the University of Western Australia, and graduated with distinctions in medicine and surgery. He subsequently trained in otolaryngology, head and neck surgery in London and Perth, completed a fellowship in pediatric otolaryngology with Professor Robin Cotton. He has published over 100 papers in peer-reviewed journals, chapters, and textbooks, and it is frequently invited to speak at national and international meetings. The topic for today about swallowing disorders in pediatric. I request Dr. Shayan to go ahead with his talk.
Thank you for the opportunity to present to you today on the topic of the surgical management of sialorrhea, focusing on chronic posterior drooling and chronic pulmonary aspiration. Common causes of dysphagia in children include laryngomalacia in neonates, adenotonsillar hypertrophy in older children, cleft lip and palate, macroglossia, especially in syndromic children with Down syndrome, Beckwith-Wiedemann, etc. Unilateral vocal fold paralysis, which we normally see as an iatrogenic problem following cardiac or esophageal surgery, a laryngeal cleft, or tracheoesophageal fistula. In general, most of these conditions are diagnosed relatively easily, and the treatment is relatively straightforward. Essentially, fixing the anatomical anomaly results in close to complete cure. Some of the less common lesions that cause dysphagia in children are listed adjacent. Patients with, for example, CHARGE syndrome often present with dysphagia and chronic aspiration. Those with esophageal disease, such as eosinophilic esophagitis, may present with dysphagia, especially to boluses, reflux disease, and so on. The topic is wide. I'm going to focus today more on one problem that I find especially challenging, and that is the management of salivary aspiration and sialorrhea. Dysphagia is best managed by a multidisciplinary team. At our hospital, we have a multidisciplinary team that extends beyond those listed in this slide. When dealing with dysphagia, one needs to separate a behavioral feeding disorder from a swallowing disorder. A feeding disorder is associated with behaviors which are aversive or associated with other conditions such as autism, where there is a preference for certain kinds of food or colors of food. Dysphagia is associated with changes in the oral preparatory phase, oral transportation phase, pharyngeal phase, or the esophageal phase of swallowing. Patients with laryngeal clefts may present with polyhydramnios or preterm birth. However, patients with type 1 and 2 clefts often present later than in the immediate perinatal period. They may present with coughing, choking, feeding difficulty, failure to thrive, and recurrent symptoms of aspiration or lower respiratory tract infection. They sometimes present with stridor if they have prolapsing redundant arytenoid tissue. Type 1 laryngeal clefts and deep interarytenoid notches often present very much like laryngomalacia. They also may coexist with laryngomalacia and certainly mimic laryngomalacia. When is a deep notch a type 1 cleft? In our patient population, if the patient is aspirating, we will treat them like they have a type 1 laryngeal cleft. The diagnosis is made on history, examination, video fluoroscopy, FEES studies, and a microlaryngoscopy is performed to confirm the diagnosis. The FEES study, as you know, is when a patient under endoscopic evaluation performs a swallow study using dye in their feed to assess if there is any aspiration or any dysphagia. Most of our patients with deep interarytenoid notches or with type 1 clefts are managed with injection laryngoplasty. A preferred option is Juvederm Ultra XC. In patients who present with recurrent symptoms or in whom the symptoms are severe, we may proceed directly to a surgical repair. Flaps are raised using a CO2 laser or cold steel, and then a single layer of suture using a 5-0 Vicryl is used to close the defects. Very rarely, type 2 laryngeal clefts may require a laryngo fissure. Another area of interest of mine is management of H-type tracheoesophageal fistulas, as seen here. At our institution, traditional esophageal atresia and tracheoesophageal fistulas are managed by the general pediatric surgeons. However, H-type or the type E fistulas usually end up in the hands of the ENT surgeon, as the diagnosis is often delayed and patients present with chronic respiratory symptoms and symptoms of aspiration. The diagnosis is made with contrast studies and bronchoscopy. The traditional approach to managing these H-type fistulas is an extraluminal approach with the patient intubated, the neck incision made, the fistula approached external to the esophagus and trachea, transected and ligated. We found that this technique increased the risk of injury to the recurrent laryngeal nerves, and often the fistula was very hard to find. So instead we pioneered this approach of an extended tracheotomy, where an anterior tracheal incision is made and the fistula is approached directly, as is seen in these images, and subsequently identified, transected, the esophagus closed, and then the posterior wall of the trachea is closed directly, and the anterior wall of the trachea subsequently closed directly. And during the procedure, an endotracheal tube is placed in the distal airway, enabling ventilation. The slide tracheoplasty approach for treating fistulas was pioneered by my colleagues at Cincinnati Children's Hospital, Matt Provenzano and Michael Rutter, who you would all know of. And in this procedure, the recurrent fistula is approached externally, the trachea transected, folded, and the fistulous area of the trachea is used to repair the esophageal end of the fistula, and the trachea is then closed primarily in a slide fashion, as can be seen in these videos here, in this patient with a very large tracheoesophageal fistula recurrence, which subsequently was managed using the slide tracheoplasty approach. And apart from that loose stitch in the trachea, you can see that the fistula is well closed. And this slide demonstrates schematically what is done, with a transection of the fistulous area of the trachea used to repair the esophagus, and then the trachea directly anastomosed in an oblique fashion. Chronic pulmonary aspiration is the occurrence of repeated passage of liquid or solid below the vocal cords into the trachea, as seen on this video fluoroscopic study. Today's presentation is mainly about salivary aspiration. However, both oral intake and gastroesophageal reflux content can be aspirated. The video here depicting one of the rarer causes of aspiration, an H-type tracheoesophageal fistula. Anterior drooling is the unintentional loss of saliva from the mouth, a cosmetic issue and a lifestyle issue, but often not leading to too many general medical issues. Posterior drooling, however, is the aspiration of saliva from the hypopharynx into the larynx and then into the trachea, resulting in chronic pulmonary disease. Although there are many mechanisms of loss of salivary control, in general, most posterior drooling is due to impaired neuromuscular control, seen in select populations of children. These issues can be motor or sensory, global or focal. In some patients, structural pathology of the pharynx or larynx may also be present, such as in the case of this laryngeal cleft. Chronic salivary aspiration results in recurrent lower respiratory tract infections, eventually leading to chronic lung disease. The diagnosis is usually based on a variety of different investigations. To confirm the presence of aspiration, one can perform a FEES study, as shown here, or a video fluoroscopy, in children with a tracheostomy, Dye testing may also be useful. In some cases, a radionucleosalivagram will confirm the diagnosis. Imaging of the chest can also be performed to assess the state of the lungs. Bronchoalveolar lavage with histopathological assessment of the secretions for lipid-laden macrophages is also used. Non-surgical treatments of sialorrhea include medications such as scopolamine or glycopyrrolate. Adverse effects of these drugs include irritability, restlessness, sedation, or delirium. Botulinum toxin blocks the release of acetylcholine at the cholinergic synapses and can thus block cholinergic parasympathetic secretomotor fibers of the salivary glands. Occasionally, dysphagia due to the effects on pharyngeal musculature may occur. This has been a very useful procedure in children who regularly have sedation for limb injections. The surgical management of chronic salivary aspiration include adjunctive procedures to reduce flow of saliva. These are the most commonly used procedures, and more definitive procedures to divert the flow of saliva from the larynx. The common salivary flow reduction procedures include foreduct ligation, submandibular gland excision, often in conjunction with parotid duct ligation, and rarely tympanic neurectomy. Definitive procedures include laryngeal diversion, laryngotracheal separation, laryngectomy, or in some cases a tracheostomy, via which suctioning of secretions can be performed easily. Foreduct ligation has the advantages of being an easy procedure. The question of whether just the submandibular ducts or all four ducts, submandibular and parotid, should be ligated has not been answered. The disadvantages are that the recurrence rates vary from 30 to 100%. Complications include increased risk of dental caries, facial swelling in parotid duct ligation, delayed reinitiation of oral feeding, aspiration pneumonia, and ranula formation. Salivary duct relocation or rerouting is an effective procedure for anterior drooling, but is not widely practiced in neurologically challenged children due to the risk of exacerbating posterior drooling and hence aspiration of saliva. At our institution, patients who fail medical therapy and Botox are offered submandibular gland excision and bilateral parotid duct ligation. The submandibular gland excision operation eliminates saliva production in a resting state, and the parotid duct ligation decreases saliva secretion in response to food stimulation. It is a relatively low morbidity operation. Occasionally, there may be parotitis requiring antibiotic therapy, and xerostomia is not uncommon, although easily managed. Laryngotracheal separation or diversion operations are offered to patients who fail salivary gland surgery. Usually, these patients are tracheostomy dependent, gastrostomy tube fed, have severe neurological dysfunction, and are nonverbal. I would like to report to you a retrospective chart review of all of our patients who underwent surgery for chronic salivary aspiration between the years of 2006 and 2013. We inspected their operation records and clinic records. 12 patients were identified. Age ranges included 3 and 21. The mean age was 11.4. There were 6 males and 6 females. 10 children had a diagnosis of cerebral palsy, 7 had a tracheostomy, 10 had a gastrostomy tube, and 2 had had previous surgical treatment for gastroesophageal reflux disease. 11 patients underwent submandibular gland excision and parotid duct ligation. 3 patients underwent laryngeal procedures. 1, a laryngotracheal separation as a first step. 1, a laryngotracheal separation for failed submandibular gland excision and parotid duct ligation. And 1 had a laryngoplasty with epiglotopexy and vocal fold medialization for a failed submandibular gland excision. 1 patient had a postoperative hematoma. Otherwise, there were no other complications. We halved the rate of hospital admissions, and in fact, the majority of patients being admitted for lower respiratory tract infections went down to 0, and these findings were statistically significant. So aspiration is a major problem in neurologically challenged children. Since the majority of these children are enterally fed, saliva is the biggest cause of aspiration. There is not much published on the management of chronic salivary aspiration in comparison to anterior drooling, where there are hundreds of publications. Mark Gerber, when he was a fellow at Cincinnati Children's, published this review of 16 patients who underwent bilateral submandibular gland excision and bilateral parotid duct ligation. The outcome measures showed that the number of lower respiratory tract infections 1 year before and after the surgery was reduced significantly. And on parent questionnaires, 73% noted an improvement in quality of life. As a fellow at Cincinnati Children's Hospital, we published on a larger series of cases. The results showed that patients under the age of 3 benefited the most, whereas older patients did not show any reduction in hospitalizations for lower respiratory tract infections following submandibular gland excision and parotid duct ligation. We felt that this was due to the fact that the majority had already developed chronic lung disease. A more recent study from Brazil has showed that submandibular gland excision and parotid duct ligation in children with cerebral palsy has resulted in reduced lower respiratory tract infection rates, reduced days of hospitalization due to pneumonia, and reduced suction of the tracheostomy tube. Oh, by the way, I cordially invite all of you, to Fiji in July 2 to 6, 2023 for the South Pacific Otorhinolaryngology Forum. I am the convener and I would love to see you all there. Thank you very much. Now for the rest of the presentation. This study, a meta-analysis on anterior rather than posterior drooling outcomes, showed that the most successful procedure for reducing anterior drooling was submandibular gland excision and parotid duct ligation or parotid duct rerouting. Submandibular gland excision and parotid duct ligation is a method to reduce chronic salivary aspiration. In this area where there is a paucity of research, our study and others have shown some benefit with the rates of pneumonia and hospitalization. We also support the use of laryngotracheal separation or other diversion procedures in cases of intractable aspiration. Thank you very much for your attention.
Thank you, sir, for your informative presentation. Now our next lecture will be about role of antibiotics in chronic aspiration, will be given by Dr. Juliana. She is the director of Pediatric Voice Clinic at Texas Children's Hospitals, trained in both pediatric otolaryngology and laryngology. She has published groundbreaking grant-supported research on laryngeal ultrasound as well as a transoral laryngoscopy in children. Thank you, Dr. Juliana, for your present. You may start, please.
Good morning. Thank you so much for asking me to present. Can you hear me?
Yes, dear. Yes.
All right. I am. And are you able to see my slides here?
Yes.
Well, thank you so much for inviting me to talk. Yes, I'm Juliana Ancasawan. I am actually laryngologist at Texas Children's and Baylor College of Medicine. And again, yes, they've asked me to speak on antibiotics and chronic aspiration. So a few disclosures. I do have, I am involved in scientific advisory boards for Inovio, Ambu, and some royalties from Springer, but these are not relevant to this talk. Just to give you a really broad overview about why we care about aspiration. I know we all care about aspiration, but the very broad overview is that, acute aspiration can make you sick, right? You can get acute pneumonia, but then you can end up with lung changes. And when you have aspiration that goes on for a long time, you can start developing fibrosis and scarring of the lungs. And then the end stage of recurrent aspiration is bronchiectasis. You can get bronchiolitis obliterans. These are the kids who sometimes even have to get lung transplants for these chronic aspirations. So I know we always talk about aspiration a lot, but thinking about kind of what are the other than acute pneumonia, what are the long-term sequelae of aspiration, and kind of how can we intervene here to help prevent the progression to end-stage disease? So acute pneumonia, this is taken broadly from both the adult and pediatric literature, but what increases your risk of pneumonia other than aspiration of food contents, right? The aspirated things that you eat would be poor dentition. So even our kids and individuals who do not eat by mouth, trying to make sure that their oral care and dentition are as good as possible. And certainly reflux of gastric contents, if they have delayed gastric emptying and they're vomiting a lot, can be even worse due to the pH, because you can actually get, a pneumonitis, which actually physiologically is different from acute pneumonia, but it certainly exacerbates things. And then, PPIs, we always, I know as otolaryngologists, we use PPIs quite liberally, but it does change the microbiome of your stomach contents. And there are plenty of data that show that being on PPIs actually increases your risk of acute pneumonia, whether it changes your gastric microbiome or your oral flora or whatever it is, it can indeed increase the risk of acute pneumonia. So, I know our NICU and ICUs have really been trying to be very cognizant about which patients we place on PPIs. And I think we should be really thoughtful about this because of these risks, especially in our kids who are imperfect swallowers. The organisms that can cause an acute pneumonia do vary. And some of this depends on whether this is an acute community acquired or this is chronic, or whether there is vomiting involved in the etiology of the aspiration pneumonia. And then I know the what I've been asked to talk about is chronic aspiration. I want to put up the drugs that we use for acute aspiration so that we can use this as a contradistinction. So, acute pneumonias are treated with a lot of your penicillin-based, some of your cephalosporins, specifically in immunocompromised patients, aminoglycosides may be used. But the point being here actually is that these are relatively short courses. These are a week-long course of antibiotics for acute pneumonia. I want to spend some time talking about PBB. So I will say, when I was a resident, I never heard of PBB. I didn't know anything about it. And then since working in the aerodigestive clinic over the last 12 years, really, this is what we talk about a lot, this protracted bacterial bronchitis. So what is the definition? It is a wet cough that is lasting greater than 4 weeks without, and responds to antibiotics and doesn't have another explanation for specific cough. So, this definition comes out from our pulmonary colleagues' literature, and it is interesting to me. It doesn't involve BAL as part of the diagnostic criteria. I will say in our aerodigestive clinic, we do a lot of BALs to help identify specific organisms that are at risk for developing, that need to be treated, and to help make the diagnosis of PBB. Because part of the reason is we do see a lot of other alternative causes for cough. So I think it's interesting, because this has become such a hot topic in the world of pediatrics and pediatric pulm. The definition actually, it does not involve any invasive BAL, like having to get cultures from the lungs, but this is the definition. The risk factors are kids who attend daycare, they get sick more often, and symptoms, they're coughing all the time, they can't sleep well, and they have some shortness of breath. And then the most common organisms we see are the ones that cause most of our head and neck, our otolaryngologic infections in children. There's strep pneuma, Moraxella, and Haemophilus. This is what we see in the ear. This is what we often see in the nose. And again, this is what we see in PBB. And the reason why I think folks get really are really worried about PBB is that there are data that show that if you have greater than 3 episodes a year, the children have an increased risk of the development of bronchiectasis, which can be actual long-term changes in the structural form of your bronchi. And I will talk a little bit more about bronchiectasis later in the talk. But if you remember from the previous slide, is bronchiectasis is one of these long-term sequelae that we really worry about from chronic aspiration. So PBB, talking to my pulmonary colleagues, this has probably been around for a long time, but our attention is a lot more on it now because of this concern about progression to bronchiectasis long-term. So how do you treat PBB? There was this Cochrane review many years ago, which showed, everyone thought, oh, we should treat this with antibiotics, but there was the end result of that Cochrane review was that we don't actually have good data to support the use of chronic antibiotics. So that Cochrane review actually prompted this really great randomized controlled trial of the use of amoxicillin clavulanic acid, Augmentin, for the treatment of PBB. And I think this is great because in otolaryngology, we don't have a lot of prospective randomized controlled trials. So they really did this. It was placebo controlled. They put kids on Augmentin for 2 weeks and actually tried to quantify the cough scores. Now, again, these are not BAL confirmed, and not all of them. They did have some subset of the patients, but they were really talking about cough. And basically, they showed that they could improve cough scores with the use of Augmentin. And so this is our first line management at our institution. This is what our pediatric pulm folks will do, are these 14-day courses of Augmentin for the treatment of PBB. And you'll remember, in contradistinction again to the acute pneumonia, this is a longer course of antibiotics. Now, there is no, I couldn't really find any data to support this. We had a pediatric pulmonologist previously who would treat our PBB patients for even longer courses, 3-4 weeks of antibiotics to try to eradicate these bacteria. Again, there's no clear data to support that. The data right now is really only for 14 days for what it's worth. And then the other question, for which I really only could find one paper, but I will say clinically our pediatric pulmonologists do, if we diagnose the patients with tracheomalacia, they actually have a lower threshold to treat with antibiotics than they will for otherwise healthy kids, and to do these longer protracted courses because they feel that these children are at additional risk for developing PBB. The reason is, as you guys are probably well aware, is that tracheomalacia, they have this floppiness of the trachea. So they get this really loud, brassy cough, and these kids cough every day, but when they get sick, they cough even more. But because of the floppiness of the airway, this is a loud cough, but it's an ineffective cough, right? They're unable to really clear their secretions well. And so the feeling from our pediatric pulmonologists is that these kids are at higher risk of developing pneumonia because of all this mucus trapping. Bacteria go to standing mucus like mosquitoes to water, right? So they have a lower threshold to treat these kids with antibiotics, in addition to doing very aggressive pulmonary clearance, whether it be chest PT, vest, a cappella, whatever it is that they choose to use, usually starting with just chest clapping for most of our kids. First off. So I think tracheomalacia, again, the data actually, there isn't much data that I could find in the literature, but I will say clinically that is how our colleagues are quite aggressive with antibiotic management for our kids with tracheomalacia. Again, thinking that they're at higher risk for developing acute pneumonia and PBB, and then bronchiectasis. So, the pediatric pulmonologists, they talk about this vicious cycle, and this is a picture that I took out of a paper from Lancet, which kind of sort of diagrams this again. So why do we care about PBB? Well, we care about PBB again because this chronic infections eventually will lead to epithelial changes, and then changes in airway remodeling and changes in the lungs that can eventually become irreversible, leading to hypoxemia, exercise intolerance. And these patients, again, some of them go on to needing lung transplant for this. And there are things that we can't affect, genetics. There's that may make some more at risk for these. Maybe there are immune deficiencies, but there are things that we can affect. Things like smoking in the home. Smoke exposure is a risk for the development of PBB. Again, hygiene, health hygiene, other exposures in the house. Again, it's hard to take kids out of daycare. A lot of our families are not, don't have the socioeconomic freedom to be able to keep their kids home. But the truth is, kids stay home, they're going to be less likely to be exposed. You saw that going to daycare is a risk for PBB. So if we are able to affect some of these other modifiable risk factors, we can try. We actually were wondering, this is a study that we did at Texas Children's to look at whether, we're coming from this from an aerodigestive perspective, and, I'm a surgeon as an ENT. Is there something that I can do to help affect this? So we looked at our incidence of type 1 laryngeal clefts and pathologic bacterial overgrowth. We didn't look specifically at PBB, but if you have this pathological bacterial overgrowth, these kids, there's a strong correlation with PBB in these kids. And we found that, when we controlled for all the other different risk factors, looking at developmental delay, reflux, tracheomalacia, there's other things. Like I said, PBB, technically, you shouldn't have another reason for cough. So we tried to control for these. That type 1 laryngeal cleft specifically did increase the risk of bacterial overgrowth, which again, for us points to, we should be relatively aggressive with trying to treat our type 1 laryngeal clefts to decrease this risk of bacterial overgrowth, recurrent pneumonia, and chronic infection. Technically, again, does this meet the criteria for PBB? Because that technically should not have a underlying cause for cough. But the point being is, it's again part of this vicious cycle. You've got this bacterial overgrowth and then potential for bronchiectasis in theory. So I know this has probably been covered in other talks, but, how do we make the diagnosis of a type 1 laryngeal cleft? We use video swallow study, we use FEES, and you can see examples of, you can see that intrusion, that posterior aspiration. And I've put still images from our video swallow study and our FEES over here on the right. And then going to the OR to palpate that interrytenoid area. I'm just going to put a plug in that in infants who are strictly breastfeeding, we use quite a lot of FEES, where we will do the FEES actively while the baby is breastfeeding. And it's a really nice other option, especially for our children who don't take the bottle, and then a videoscopic swallow study is not an option. And then I know this has been covered previously, but, we do lots of cleft repairs. And again, our technique is not dramatically different from anyone else's. But my argument again would be is that this increases the risk of lung infection. And while treating with antibiotics is important, you do worry about antibiotic resistance and the sequelae of recurrent courses of antibiotics. So again, trying to be aggressive with our controlling whatever risk factors we can help with as surgeons to help out our pulmonary colleagues. On that same note, we've looked at this in our institution, the risk of aspiration with vocal fold movement problems. This study we did was specifically in our post-cardiac repair populations, but we looked at a lot of variables, including the types of surgery they had. We used the stat categories, which you can see here, as well as the presence of other neurologic diagnoses and prematurity that can increase the risk of aspiration. We found that having a vocal fold paralysis increases your risk of silent aspiration, right? Which is not shocking to most of us, but we wanted to get clear data on this. This is again, in our cardiac population, we've looked at, the prolonged lengths of stay, and they have higher risks of readmission if they have a vocal fold paralysis. So again, what can we do as surgeons? We can try to do vocal fold medialization to try to decrease the risk of aspiration, to decrease the need for antibiotic use. This is data, actually my own data. This is in my adult population about doing early bedside vocal fold augmentations that we can decrease the acute pulmonary complications of after aortic surgery. But we've looked at this in various ways, and also that the earlier we do the vocal fold medialization, the more we can help decrease the inpatients. These are acute pulmonary complications. The question always is, should we approach this in our pediatric kids? Because in this adult patient population, I actually just do these at the bedside awake. We just roll up to the bedside in the ICU, put a scope in their nose and a needle through their neck. But in the pediatric population, it requires another trip to the OR. So we're still looking at this. I don't know whether it's worth the risk of going back to the OR, or whether we should treat it more with changing flow rates through thickening, nipple sizes, positioning, which is the primary way that we treat our kids with vocal fold paralysis. But more to come on that. Again, we're just trying to help out our pulmonary colleagues here. This was a systematic review of augmentation in adults and the impact on aspiration. And this Babak Sadoki did this systematic review, which suggests that, at least in adults, early augmentation seems to help. Again, the question is, does it help in kids? This was a systematic review of doing reinnervations to help with swallow. And again, the data, there's are small numbers, but suggests that reinnervation, which I think of unilateral reinnervation, we're talking about for unilateral paralyses, which is, I think of as a vocal fold medialization procedure. This isn't really a dynamic procedure, may help with aspiration. And again, because I'm a surgeon and I'm trying to think about ways that we can help our pediatric colleagues, non-selective laryngeal reinnervation is a pretty simple surgery where we're hooking the ANSA into the RLN. And I do it primarily for voice, but a secondary gain is that we may be able to improve glottic competence, decrease the risk of aspiration, decrease the risk of long-term pulmonary injury. Again, we have limited data on this, but perhaps this is a way we can help out. So moving back to kind of the medical part. So bronchiectasis, okay, this is the long-term sequelae. We haven't done a good job with the acute pneumonias, the chronic suppurative the bronchitis. And then they progress to bronchiectasis. But how do you make the diagnosis of bronchiectasis? So this definition is a wet cough that doesn't respond to 4 weeks of oral antibiotics. These folks can have chest pain and dyspnea. They can have digital clubbing because of chronic hypoxemia, failure to thrive. I have a teenage patient currently who's being worked up for this. And then it's interesting to me, the definition of bronchiectasis, it's really a structural airway disease. You've got these clinical findings, but it's really the diagnosis is made on CT. And then again, here are the organisms that may be at risk. Again, very similar, except that you've got a little bit of staph playing here and Pseudomonas in the long term. I put adenovirus here because the thought is that adenovirus may contribute to the development of bronchiectasis. And then here are the radiographic findings. In the early findings, you can the bronchi can take on this really cylindrical form. You can see the bronchi going out to the margins on CT. In the later findings and irreversible findings in the lower two slides here, you can really see these really large dilated cavitary spaces. And then one of the things that my pulmonary colleagues have taught me to do is to look at the relative bronchial diameter to the neighboring vessels. And when the bronchi start looking bigger than the neighboring vessels, then it's possible bronchiectasis. And then this is a table looking at bronchiectasis and how the ways in which we treat it. Again, this is generally done by our pulmonary colleagues. There are other drugs that are being looked at to treat long-term bronchitis beyond antibiotic use alone, but it seems to be a little bit controversial. When the antibiotic treatment, you can see here, again, Augmentin is the primary drug of choice, again here, except if they happen to have developed Pseudomonas. And Pseudomonas can be a big problem, right? Because you get these biofilms and it can be very difficult to clear. This is from the same paper talking about trying to clear Pseudomonas quickly, because once they get chronic Pseudomonas, this becomes like the CF patients, right? It can be really difficult to clear this. And these are the kids who are on inhaled antibiotics in addition to oral antibiotics. And again, if you're worried more about Pseudomonas, you do add in ciprofloxacin, some of these fluoroquinolones. A lot of this has to be BAL supported. So these are the cases in which a BAL can be helpful to help our pulmonology colleagues direct their antibiotic treatment. So I do want to bring up the immune deficiency, because we have definitely run into this in our Aero clinic. These kids who keep getting sick, they keep getting pulmonary infections. I've done what I can as a surgeon. I've repaired their cleft. I have re-repaired their cleft. Their aspiration isn't really that significant. You know, they maybe penetrate a little bit in their swallow study, which granted is a moment in time. But we're spinning our wheels. And this is the point at which we involve our allergy immunology colleagues to see, okay, is this an immune deficiency? And so here are the criteria. There seems to be some disagreement between the European and US practice patterns. But there are some of these kids where they will either put them on prophylactic antibiotics, and Azithro versus Bactrim seems, and the decision-making for this seems to be stylistic as far as I can tell between our immune colleagues. And if that doesn't help, they have put some of our kids on immunotherapy with our infusions with IVIG, and it has been a game changer. This is the only thing in my mind for some of these kids that really is able to make a difference in their recurrent infections, is actually giving them immunoglobulin. So thank you again for asking me to talk. That was a quick overview. This is our group at Texas Children's. Again, as surgeons, I'll be honest, I don't do most of the antibiotic management. I really have to partner with our pulmonary colleagues and our allergy immunology colleagues on this. Thank you.
Thank you, Dr. Juliana, for an enlightening presentation. We got a few questions from the audience. Let's see. Psychological dysphagia. There is a questions about what is the psychological dysphagia?
Yeah, well,
yes.
Yeah,
there is a question about psychological. Yes.
Well, psychological dysphagia, or actually more popularly called psychogenic dysphagia, is a fear of swallowing anything. It's occasionally associated with globus too. So these patients, unfortunately, it's quite rare. But then these patients, usually when you do endoscopic evaluation, or you go ahead and do an esophagoscopy, you'll realize that these patients don't really have an organic problem, or even for that matter, motility disorder of sorts. But then in spite of that, they fear the process of swallowing. So they feel that the food gets stuck in the throat. So it's usually these patients do reasonably well if you give them behavioral therapy. And medicines, well, usually these patients are afraid to take medicines too. So behavioral therapy, you can probably, while doing an endoscopy, you can give them biofeedback to show that they are actually swallowing reasonably well. And I think that's the only way forward with patients of psychogenic dysphagia. It's quite an unfortunate disorder.
Thank you, Dr. The other question for Dr. Juliana, the questions for you. What is the psychological? No, this is, what are the protocol difference in pediatric fees comparing with adult fees?
Oh, that's a big, that's a big topic. You know, pediatric fees. Ooh, there's a lot of, you got to pick your kid carefully. We do it in our young infants. But then when they get between like 1 year to 5 years, it's almost impossible in my mind to get it, because they're going to fight you. But the infants, it's great, especially if they're hungry and they soothe with the bottle. But yeah, you can't do some of our adaptive techniques. Like you can't make a kid, like an infant, do a chin tuck or something like that. But we can do positioning maneuvers. So basically you put the scope in the nose, you put the bottle in the mouth. We use sucrose, some sweeties to calm them down. And you just try to get them to latch to the bottle. And you're watching, we can put them in different positions, side lying, upright. Again, we can look at breastfeeding, which I think is a wonderful use of fees, because we definitely have kids who don't take a bottle. And we can try different flow rates. We can do thickening, we can do nipple types and different bottle types. Clearly, we're not looking at solids in infants, but I think it's a great way to look at feeding. We use this a lot in our ICU graduates, like our little babies who come out with an NG tube after their cardiac surgery, and we want to see if we can advance their feeds. But yeah, there is an element of luck here, because some of the kids, they're just not going to do it. Like, yeah.
The next question is also that there is a doubt between the diameters of scope used in pediatric fees. Is it 2.9 millimeter or 3.8 millimeter?
Oh, we use the smallest baby tiny fibroscope. So we have a little 2.2 millimeter pediatric. The image quality is not awesome, I'm going to tell you, but it's not as good as a digital scope. I don't use our digital distal chip scopes and the baby fees. I go for the smallest thing we can get in there.
Thank you, Dr. Juliana. And there's also, is the section.
So Heba, can I just add a little to that? So for kids, say in the age group of maybe 1.5 to 5 years of age, I could well go in for a scope which has approximately a 3.5 millimeters diameter. It's a battle against the image quality and of course the introduction of the scope, which can be a little tight. But then for infants smaller, kids who are smaller than 1 year of age, I would probably go for something which is less than 3 millimeters. But otherwise, around 3.5, 3.6 millimeter scope should be a fair fit for kids between the age of 1.5 to 5 years.
But it's a debate between, yeah, you can put the bigger scope in, but trying to get them to soothe and do the fees. That's the big thing, is like I use this because I actually prefer the bigger digital scope when I'm trying to do a diagnostic scope to see the details. And certainly if I'm thinking about strobing, I'm going to do a big digital scope so I can get enough light. But when I'm doing a fees and I just want the kid to calm down, I go for the smallest, softest thing I can find to see if they'll take the bottle, because trying to get them to calm down and take the bottle is the hardest part. You know, we turn down the lights, the mom is trying to talk to them, we have them bundled, we're doing all this stuff to try to get them to calm down and just take the bottle. Because you can look at because if they're screaming at the top of their lungs and they aspirate, you don't know whether that has any reflection on what happens in them in a regular feed, because we really want them to get into a rhythm, into a suck, swallow, breathe rhythm.
Ma'am, there is another question regarding, is the section port necessary for fees working channel? I mean, the section port, which means the working channel, is it necessary for fees endoscopy?
Yeah, well, so should I answer that, or is Dr. Juliana?
I mean, we don't use it. It's up to you.
So neither do we use it. But then off late, there have been a few instances where I have used a suction channel with a flexible laryngoscope. And to be honest, it kind of is a sort of relief to have a suction channel, in the sense that if there are minor amounts of aspiration, you could suction them out, or if the patient is having some penetration, you could suction them out. So it's always a relief. But then the problem on the other side is, whenever a suction channel is added to the scope diameter obviously increases. So that becomes a bit of a tussle there. But then, yes, we have been doing fees without a suction channel, obviously. But the thoughts could be put, there could be some scopies wherein you feel that the patient might have a scope for aspiration, where maybe using a suction channel might help. So it's something worth exploring.
We don't. I want the smallest scope, smallest scope possible.
Thank you, Dr. Juliana and Dr. Womack. And now I'm giving over to Dr. Sachin Gandhi, our director and HOD of Otolaryngology Department and Voice Clinic in Dinanath Mangeshkar Hospital. Sir, you can have.
Good afternoon. I would like to thank all the faculty members for the last session of the webinar series. I would like to thank Rohan, Dr. Shan, Dr. Julina, and Nilanjan who have conducted this webinar on dysphagia. For last 9 sessions, we started in April. We have got more than 5,000 otolaryngologists and speech pathologists around Asia Pacific and other nations who have registered and participated actively for this web series or webinars, and has made this a great success. With this dysphagia topic, or maybe dysphagia second session, we are going to close the first series of webinars. Next year, as we have talked about in last session, we are going to come back the same series in some different format, in which it would be more of demonstrations and case presentations. I would like to thank some backstage supporters of this web series. Digital Infomedia, Mr. Dinesh, who heads this company, have made this web series quite interactive and reachable in all parts of the continents and world. So I would like to thank Mr. Dinesh and his company, Digital Infomedia. I would like to thank GSK Pharmaceuticals who have supported this series of webinars on laryngology. I would like to thank all the faculty members. Last but not the least, Dr. Abhisha and her team at Voice Clinic of Dinanath Mangeshkar Hospital, Pune in India. And of course, all the listeners who have made this series a most successful interactive sessions, interactive one from all parts of the world. Mr. Vasant Oswal, I would like to mention his name. He has been an honorary head of the department, founder of this Voice Clinic at Pune. He has put forward this idea and guiding us throughout this web series for last 9 months. and we are going to come up again with some interaction going on in the year 2023. Thank you very much, Dr. Heba. You can close this session.
Thank you, sir, for your effort and in this webinar. And I would like to thank you all for attending our session today and the whole webinars, and hope that you have had a good learning experience. Hope to see you again. Thank you.